What quality measures does your organization currently collect and report? Has your organization already begun moving from the first curve to the second curve? What strategies has your organization implemented to move towards a value-based reimbursement structure?
Your trustee's role in terms of quality for the future of healthcare is absolutely essential. As we move from our volume-based first curve to our value-based second curve, meaning from where we were rewarded based on how much we do and there was no reward for quality and efficiency, tomorrow that changes. It is a value-based reimbursement model.
We are known as one of the low-cost, high-quality providers in our service area, which is Will County, Illinois. But that wasn't always the case. That journey took us over a decade, and 12 years ago we began by establishing a quality committee of the board and really examining our quality and safety performance. What we realized is we weren't performing at the level we wanted to be, and that really began an initiative to put together a balanced scorecard where we could monitor a number of different measures of quality. And over time, we've achieved 95th percentile and above performance. What continues to happen, though, is we continue to raise the bar. So now we're looking at value-based performance metrics as well. Our board members see the performance that we're at now. We know we're working to improve it, and we know what we're going to be striving for next year, the following year, and so on. So I think it's a good way of looking ahead and helping to plan for performance improvement in the future.
The Hospital Engagement Network is an incredible opportunity for all our hospitals in our country to dramatically improve quality and patient safety. And it's such a key piece because all hospitals, all health systems are moving from the first curve to the second curve. As trustees, we all have a responsibility to organizations, but the first volume-based curve means that today, we as organizations are reimbursed based on volume, based on reimbursement by fee for service, based upon a transactional model. But the second curve is based on value, rewarding high quality and efficiency, rewarding when we're providing the most effective care across the continuum of care. So we're moving from the first curve to the second curve, and many of us feel like life in the gap, in between the first curve and the second curve. But how do we get from the first curve to the second curve? As trustees, we have a responsibility to think about the most important strategies we need to implement to go from the first curve to the second curve.
In the past, we used to be measured by fee-for-service, and we were measured by our getting people well from chronic disease or illness. In the future, we're going to be measured more and more by our outcomes. And if quality is delivered first time, every time, our outcomes will be better, our throughput of patient care delivery will be better, our physicians and patients will be more satisfied because we're not engaged in a margin of error or in repairing old wounds or damage that could have been prevented. So if we focus on quality, we establish a culture of quality and safety and compliance.
There are 4 strategies that we have identified through the American Hospital Association that are essential to succeeding in that second curve. Strategy 1 is aligning our clinicians and hospitals to be on the same page. Strategy 2 is improving quality and patient safety. Strategy 3 is improving efficiency, and strategy 4 is integrating our information systems. There are a number of important strategies, but these top 4 are critical to our roles as trustees and our hospital leaders to move us from the first volume-based curve to the second value-based curve. As we think about these strategic questions and these strategies, it really gets to our role, our opportunity to provide the best care for the patients in our communities.
Our board is involved in helping us develop strategies and metrics. Now, clearly, they accept the recommendations of management, which are often and many times mandated by CMS. But that's what we measure, not how we measure, and also why we measure. And so we have deep discussions with our boards about why we would track and trend certain indicators and why that matters to, ultimately, patient care and patient outcomes. And additionally, we've also expanded the purview, if you will, of our Quality and Safety Committee to include a lot of our performance improvement and process redesign metrics. We have what we call Value Care at Baptist Healthcare. That is our initiative to drive quality at a lower price point. And that includes process redesign. It includes variability removal, so DRG standardization. It includes care management across the continuum. It includes physician integration, and it includes the data analytics around that to support that. So that's value care. And so it goes beyond just the mandated what you got to track in terms of process measures and outcomes measures. It also is now broadened to include variability and process redesign, because by definition, variability equals poor quality and higher costs.
So as a trustee, your role is critical to ensure that your organization is implementing these 4 must-do strategies. You need to ask if your organization is ready and able to deliver team-based care. Much of what happens in the future is care delivered by teams of providers. And so you must ask, are you ready to do that? You must also ask a strategic question on what are the most important needs for your community. What are the most important primary health services you can provide to your community? And that's an important question. As you move down these paths, it's critical to, again, implement quality and patient safety, improve efficiency, connect HIT, and align clinicians and hospitals, which gets us to a deep, focused review of your patient safety metrics across all areas to improve care.
In an idealized future, we'll be measuring and reporting against a common set of nationally agreed upon safety and quality performance indicators. Clinicians will be seeking more and more data in order to further inform them on how to improve against those indicators. Managers will be seeing and clinicians will be seeing how that performance drives organizational performance and success. And patients will be referencing that publicly available data to make wise and informed decisions about where to get their care and what they can do to improve the outcomes in these areas themselves as partners in the patient care process. That's a future that I think we all want to see come about, and movement toward that is picking up steam all of the time, and I think that's a great thing.
The Hospital Engagement Network provides an opportunity for us as trustees to look at, are we looking at the right information, the right quality and patient safety metrics? Are we implementing our strategies reliably and at a fast pace so that we can improve care for our patients? Are we supporting all our work by developing the capability of improvement by our leaders, by looking at the right data, by tracking the right quality data, by discussing this quality information at our boardrooms? Those are all key pieces for us as trustees. So as a trustee, the role is challenging but exciting and so critical in terms of the stewardship and our responsibility to our communities to improve care as fast as possible for our patients.
Performance needs to be tracked routinely to eliminate patient harm and improve both quality and safety. Boards must be engaged in asking strategic questions of their organizations to assess readiness to move from the first to second curve, and then use the answers to help direct their actions. Boards must oversee and ensure that strategies are put in place to help the transition from first to second curve while improving quality for patients.